What do you need? You need some handouts or something? Yeah, I'm putting them in the order we're going to cover.
Okay.
Nice to meet you.
Myself. Thank you.
Yeah, definitely.
After why you asked for it?
Yeah.
Of course, looking forward to it. Happy to help.
Get it done.
Oh my God.
Yeah, that's it. I'll do that,
Only by reputation. There's another presentation in the right folder.
fantastic.
Hello, I'm Donna. I'm Julie Driscoll. Nice to meet you. Yes. Did you send all the information? I did, yeah. I saw your name. That's a team effort. Yeah, awesome. Great.
Yeah.
Excited to see what we're doing.
Yeah.
I know we're not doing hands. I know. So how many do you have?
There are 7, so 6 are in first year, and Jason is.
Good afternoon, everybody. It is 5.
It's been a while. I have a spot here for you. The red folder has all the materials.
I could just remind everyone to go ahead and turn your phones to silence.
There is the traditional donut penalty if you're cold frames. Next time you will do a donut. Okay, thank you. Well, thank you all for coming. I'm County Executive Josh Shulman. I'm going to call this meeting to order. It is now after 5:30 here on the 1st of February 2021. This agenda was posted in the office of the county clerk on the 27th day of January 2021. Notice was sent to West Bend Daily News, Express News, WIBD, WMBZ Radio, WTPM Radio, My Community Now, Hartford Times Press, Kiosk and Statesman, Washington Journal Sentinel. Individuals with disabilities requiring special accommodations for attendance at the meeting should contact the county clerk at phone number at least 48 hours prior to the meeting. All right, can we do a roll call, please? Go right down the line. Craig Sinatra is here. Dell Ellison's here. Deb Anderson's here. Jenna Whitting's here. Donna Nash is here. Nick is here. Jason's here. Is that everybody? Did I catch everybody? I think so. That's 7. All right. Stand for the Pledge of Allegiance, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. All right, so I just rattled off everybody's names, but if you would be willing, please, we'd like to just go around. If you could introduce yourself, name, your maybe employment, where you live, and 10 seconds about who you are. Craig, could you start us off?
Hi, everybody. I'm Craig Sedonico. I live in the city of West Bend over near Reckner Park. I own American companies. We are architects, construction managers in the commercial field. I've got 5 ladies at home, 4 daughters, and a great wife. I'm the past mayor of West Bend. I was mayor for a little short of 9 years, and happy to be here and to learn. Thanks for the invite.
Thanks for coming. Bill.
Dale Ellison, I'm a retired registered nurse from UWM, and I used to run, I got about 25 years or 22 years of CBRF care in the business. So I'm happy to be here.
The legend, Deb. Deb?
Hi, I'm Deb Anderson. I have been, my last job was working as the director of the senior center. And before that, I managed Riverbend Senior Village. And I've also been a caregiver for all our parents. And I was a former alder person for 2 years.
Thank you, Deb.
And I live here in West Bend.
Thank you. All right, we'll jump over to Jason quick. Jason, can you introduce yourself?
Yeah, thank you. Jason Hartland. I am the Chief Revenue Officer for the Milwaukee Brewers, and my wife, daughter, and I live in Erin.
Okay, thank you, Jason. Jana?
I am Jana Whitney. I live in Germantown, and I am representing the families and residents of Samaritan. And I am a financial advisor with Principal Financial Group, and planning for long-term care is always a conversation.
Thank you, Jana. Donna?
I'm Donna Nash. I'm also from Germantown. I work for Freighter in the Medical College of Wisconsin, Workforce Health, which is the employer services area. And I'm really glad to be here because I have an aging mother who lives right next door to me, and I know what it's like to take care of somebody. So I'm proud to be a part of this group.
My name is Nick Bush. I live in Slinger, Wisconsin. Got 2 young boys, wife's a nurse practitioner. I work for Direct Supply, and all we do is care in the senior living industry. So I've been with them over a decade and run different sales teams and met with different owners and operators over my time there across the country in different senior living communities.
Excellent. Thank you all for your introductions. The first order of business is to elect a chairperson. So somebody's got to call these meetings to order and get it going. Don't worry, you're not going to have to do a ton of work other than to convene a meeting and keep it all orderly. Although with this group, maybe that'll be a little bit more work. Do I have any nominations for a chairperson?
I would nominate Dell.
No, thank you. I don't want to be that far. But thanks.
I would nominate Craig. He's run a rowdy group before.
Way to be you, Deb.
Any further nominations? Any other nominations? Any other nominations? Hearing those, I'll ask for a consent of the group. All those in favor indicate by saying aye.
Aye.
Those opposed? I'll take that as nay.
It was just a silent eye roll.
All right, Mr. Chairman, if you proceed with number 6.
Certainly. Time to elect the vice chairperson. Are there any nominations for vice chair?
What does the vice chair do?
In case the chair can't attend, that individual will just run the meeting essentially.
I think I'm coming to the rest of the meetings, at least as my schedule looks right
Well,
now.
then I'll nominate myself for that.
Second thought, maybe they won't. Any other nominations? Anybody else? All in favor of Donna, please signify by saying aye.
Aye.
Any opposed? Congratulations, Donna. Item number 7 is a welcome and the charge from County Executive Josh Shulman to tell us all why we're here.
All right, thank you very much, Chairman Sadatico. A couple of things. First off, in front of me is a proclamation declaring this group. You all have a copy in front of you. It basically is just laying out the gist of what we're doing. I'll get into that in some more detail, but for the purposes of being official, you all have a copy, and I am officially signing the Future of the Samaritan Campus Task Force. All right, so we're official. You've officially been charged. Really, at the end, what we are trying to accomplish, it can be summed up in one question, and that's the one that's listed on your agenda, and we wanted to make sure that it was very public. And that question is, should Washington County remain in long-term care, nursing home services specifically, skilled nursing facility. As you'll see over the course of the next several meetings, Washington County has a long history in senior care, I mean, very long history. And county government in Wisconsin does as well. And all the presentations that are gonna follow me will illuminate exactly how that has been built over decades and generations, and how it has evolved in Washington County. So every time you're considering this entire discussion, but also what questions you need to ask, it should revolve around this policy question that we're really asking of you. And remember, this group, as I was just telling one of the members behind me, this group was really designed, and if you look at the proclamation, was intended to be representative of the community at large. So if you listen closely to the folks who are here on your group, on the task force, you come from all different corners of the county, you come from all different kinds of areas, expertise, registered nurse, somebody with family members, senior center experience, so on and so forth. So we're trying to pull from as large a group as possible. There was a time when we had talked about doing a referendum. This was kind of the next step rather than going that big, long approach. We decided to pull the task force together. So you're really representing all of Washington County and giving guidance to ultimately the county board on what the future ought to be. What you're going to hear over the course of the next several meetings is that counties across the state of Wisconsin do a lot of different functions, handle senior care a lot of different ways. There's no one cookie cutter way to say it must be done. Counties to our south, like Waukesha County, are not in the business of skilled nursing. Counties farther south, like Racine County, have recently gotten out of the business. Counties to our west, like Dodge County, are even more intensely in the business than we are. And you'll hear about all of those different things over the course of the next couple presentations, as well as the why they've been involved, where it started and where it's going. Ultimately, what we're asking you to do is to give a recommendation as a group. It does not have to be unanimous. There can be one recommendation from the majority indicating we'd like you to do this, and the minority can be represented going to that group as well. So this doesn't need to be a kumbaya. As a matter of fact, if it was, I'd be a little bit surprised. If it is, I hope so, but if not, that's fine. Ultimately, Paul Robach and Matt Fernald will do a lot of the facilitating. Paul is a master facilitator. So this will be the most smooth process you've ever seen. And if it's not, we have a phone number for you to call. Paul is great. He works for the UW Extension here downstairs typically, but has been with the county for many years, has led us through a number of these types of projects in the past. Matt Fernald, most recently was the deputy county executive, is currently the policy director out of my office. When I came to the county, Matt was the administrator at Samaritan campus. And he worked his way up or down, however you want to look at it, into administration. As a matter of fact, I think Dan Stoffel was the chair of that committee at the time when Matt was hired, correct? So Matt's been around the county for the past 7 years, and he's got, as I'm sure he'll tell you, he's got decades of experience in this industry. So these two guys will be your drivers as we go through the rest of the conversation. Ultimately, in your packet, you'll see a timeline that we're working towards. And I think you've all kind of got at least been able to pencil in some dates for future meetings. What we'd really like to be able to do is to give a recommendation to our county board sometime around our Human Services Committee in the month of March, our county board in the month of April. What you'll notice, and I'm sure you've seen this publicly, we are running two conversations or two projects in parallel. This conversation, which is a very high-level public policy discussion about whether or not the county should be in this business, at the same time as we're actually doing the analysis, cranking the numbers, if you will, on what does it look like if we stay in the business, whether we do that on our own with a different facility, whether we do that maybe partnering with another organization. You'll hear about all those things, but they're happening in tandem. So the reason that I really wanted to have a group like this come together and discuss if the county should remain in long-term care is twofold. One, as I already stated, not all counties do this. But really deeper than that is, why do not all counties do this? What you're gonna find with Samaritan Campus is that their history, why they exist, where they came from, is pretty humble roots. It's very governmenty, if you will, taking care of the poorest of the poor. Back, like literally the term "the poor farm" is really the roots of Samaritan, and you'll hear more about that in a little bit. But over time, what has happened is, of course, the expense has gone up and up. And so we've done different things to try and offset that cost. We now have a community-based residential facility, CBRF, we have an RCAC. Those are undoubtedly competing with the private sector, which in this county is generally frowned upon. But that has done us the favor of not requiring us to use property taxes to pay for any subsidy to Samaritan Campus. The subsidy to Samaritan Campus has been a non-issue for the better part of the last decade. The county taxpayers have not subsidized Samaritan. If you were an accountant, you could argue that that's not true, but generally speaking, there's not property tax dollars supplementing the operation. That is not going to be possible in the future, or at least not likely to be possible in the future. What's really driven us here are three key factors. One is, and if you've been in the facility, you know this immediately, built in the 1960s, it's a concrete bunker. It really is to a point, a stage where something has to happen differently. The building, its facilities, we're looking at somewhere close to $10 million if we were to try and modify, upgrade, do those types of things. So it's a massive expense on a over 50-year-old building. Second, staffing in the industry, I'm sure Dell will be able to tell you this ad nauseum, is extremely difficult, extraordinarily competitive, and the cost is going up and up and up and up. And we expect that that will continue for the foreseeable future. And third, is that we're also seeing what's the third thing? It just escaped me. So staffing, the building costs, and
Baby boomers.
no. Holy cow.
The demographics are changing.
The demographics are rapidly changing. I'll think of what the third one is.
Reimbursement.
Reimbursement, thank you very much. Yes, reimbursement is going down, and ultimately, and yeah, Patrick's like, yeah, you yell at me about this all the time. So I've been at Patrick, you'll find out in a minute, as one of these guys cranking the numbers. I've been questioning for almost a year now, what the heck's gonna happen to Medicare and Medicaid? It's completely unsustainable. You can't tell me it's gonna fund it. He'll dive you into some of those details, but Medicaid and reimbursement just in general, family care in Wisconsin is problematic. What you're gonna hear is that the private sector is basically walking away because it's that bad. We expect it'll get worse with the baby boomers coming into the generation, into the age of using facilities of this variety. So it's a financial issue in just about every way you can slice it, and we're getting hit from all three sides simultaneously. So those three key factors are really ultimately what drives us to the point of, do we stay in this business? We acknowledge that we are certainly competing to some degree with the private sector. Is that a good thing? Isn't a good thing? If we stay in the business, how do we stay in the business? All of those things will revolve around the conversations you have. At the end of the day, it's really one simple question, and that is, should Washington County remain in the long-term care industry? Very complicated question when you start to drill down. What I just talked about is really the highest level of the discussion, but the more you get into it, the harder the question gets to answer. So we felt it was really important to pose it to a group like yourselves who can tackle it, wrestle with it, and try to ultimately give some direction from as best a countywide perspective as we can get. So that is what I have with you. Welcome in charge, Mr. Chairman.
Can I
Thank
ask
you.
a question?
Bet.
You've given us 3 specifics that are negatives, okay, that make it difficult to keep it open. What is a positive?
You'll hear about those.
Okay.
You'll hear about them in a couple of different presentations about why we actually have continued in this for a long time.
Okay.
And there's plenty.
Any other questions for Josh? Moving ahead to item 8, presentations and discussion items. You leading that also, Josh? No. We're good.
So in the red folders, on the right-hand side, you have all 3 presentations for this evening, the 2 that were included in the committee packet agenda, and then the 3rd presentation by Winston.
Good evening, everyone. My name is Mary Beth Borick. I'm the campus administrator at Samaritan Campus. And I'm pleased to have been there for just shy of 4 years. Prior to that, I was 20 years the CEO of Lutheran Homes and Health Services in Fond du Lac, Wisconsin. And prior to that, 17 years as administrator of nursing facilities in Eau Claire, Wisconsin. So I go way back. So this is indeed a passion for me. I'm pleased to be able to present to you tonight. History is big in our home, and my husband used to be a history teacher. And one of the quotes I pulled out was that Thomas Jefferson wrote that, I like the dreams of the future better than the history of the past. But tonight, I think it's important to be able to share a little bit of where we've come from and the history of Samaritan Campus as we pose some of these questions. So as Josh mentioned, the term poor farm, our beginnings go way back to the 1800s. We're actually, we as a county, much like many other counties across the state and across the nation, housed the indigent and housed individuals who had either no family and nor funds or neither. So we were a working poor farm with cows and produce and quite a sustainable model at the time. And as the Social Security Act came into effect in 1935, some of those dynamics continued to change. Many of the poor farms kind of went out, exited the field or the industry, and we as a county did that as well, but however, felt the need to continue to work with that indigent population and some of our mental health folks that were within the community, and actually built the Samaritan Home in 1966. So there's a picture of the groundbreaking that actually happened at the time. The unfortunate circumstance back in the days when people were considered poor, paupers, indigent, there was a heavy social stigma that went with that at the time. Some of that carries forward, obviously, to this day and age. And so we at Samaritan care for a fair amount of individuals who have replaced funding mechanisms with Medicaid, which is for individuals who are low income or have outlived their assets. So that our average length of stay has changed dramatically, but back in the day, in the 60s or so, it was not uncommon for someone to live a 10 to 12 year length of time within the Samaritan Campus. Now that's quite shortened to less than 2 years for our long-term care residents and about 22 to 30 days with our short-term population. So as you can see, in 1968, there was actually a change. A new building was put to be built. It was built in a traditional medical model style, and this is a building that Josh referred to as the cement bunker, which is very sturdy and has held up those cement brick walls. We housed over 332 residents at the time, and it was a traditional nursing home setting where there were the double loaded quarters Most rooms were double rooms. There were a few multi-room wards that were in the facility. And most folks did not have their own bathroom. It was more of a congregate bathroom at the time. At that time, we took care of elderly, some mentally ill, and we had a specific unit to care for individuals at that time. Certainly the resident needs were not nearly as medically complex as they are in this day and age. Our building is 146,000 square feet. It is a large building. We have 5 full floors and on a partially exposed floor. We have a full basement, and again, it mirrors the needs of the medical model at the time. So we have had at that point central nurses stations. Some of that is regulatory. In the 60s, it was cement block walls that you could see pretty readily, tile floors. Minimal office space at the time because at that time there were not nearly, again, the regulations and the management structure that was required as is now. There was one large dining room for all of the 332 residents, and that was on the main level that has now become a multi-purpose room. At that time, it was solely considered a nursing home. It was not Medicare certified. That came later, and I'll talk about that in a minute. It provided, again, long-term residence care. So individuals stayed for a significant length of time, and we housed individuals that had families, some that didn't have families, but certainly needed a place to stay as well as the medical needs. We even had President Ronald Reagan step through at one point in time, which was kind of a fun picture to pull. So, in July of 2009, there was an $8.6 million remodeling to upgrade and modernize the facility. The beds at that time were reduced from 332 down to what we currently have of 131 beds, licensed beds. We became Medicare certified. That allows us to be able to access a different federal financial model, to be able to provide rehab, skilled care for at maximum 100 days. We currently have 119 private rooms. We have 6 semi-private rooms, which actually operationally we're using as single rooms. We have 4 bariatric rooms, and all of our rooms were remodeled with private baths. That was an extremely important thing to do, predominantly for the dignity of the residents that we serve, and we see that as a real high need. It met market needs at the time, and again, that was part of why that conversion was made. As the beds are reduced, there was some excess capacity within the building itself, and so our first floor was converted to what is considered a licensed community-based residential facility. As Josh mentioned, we talk about the why the remodel at the time. So it really was to address a lot of the consumer and operational concerns within the building. We needed to look at functionality for the residents. There are ongoing changes within the market, regulatory and reimbursement changes, and obviously our residents continue to change, and their needs continue to change as well. So currently we have a variety of primary populations, and again, those have changed over the years. Predominantly, our main level that you walk in on, our second floor, is predominantly short-term rehab. As I mentioned, that's pre-COVID particularly, a pretty rapid turnover for residents that come in post-hospital stay, are there for rehab and skilled nursing, and then obviously with a discharge mostly to home, some to CVRFs or other congregate care facilities. Our third floor is predominantly our dementia and cognitive disability residents. So there we talk a lot about staff having non-anxious presence, some very specific routines so that we can care for that dementia population predominantly on our third floor. Our fourth floor is our long-term care where we have significant amount of residents that have very high clinically complex needs. So residents that might have advanced Parkinson's, advanced MS, tube feeding, require a significant amount of nursing and hands-on care. We also take care of residents that are deemed chapter and designated chapter 55, and you'll hear a little bit more about that from Julie in her presentation. We are the deemed facility for Washington County, where if there is a resident or a community member that's found in the community to have some significant needs at a time when family can't help, or there is no family, or unable to locate someone in either a guardianship perspective or a power of attorney perspective, we are the location. So a recent example happened where we had it's always in the evening, 11 o'clock at night, Saturdays usually, where we get a call from the police on crisis care to indicate that there's someone that has some significant needs and they're able to medically clear them, but they need housing. This individual has families north of us and south of us, but not a huge family network. This person was very confused, safety issues with putting things in the oven, starting the oven, living in a condominium, so not only putting herself but other people at risk. And so we're a place until the court can deem where that next location is, and then we provide that care and that transition. Sometimes people are with us for a much longer period of time, where again, they have a failure to thrive, they're in a very, very, very poor living situation and have no family, and we become family and we become the location to take care of individuals that have skills.
So is that mostly mental health care?
No, it is not. No, it is not. There's oftentimes some of that mental health that's woven in there, but they're predominantly individuals that might be unable to care for themselves and put themselves or others at risk.
Mary Beth, can I just interject
Yep,
a moment?
certainly.
So one of the things you're gonna notice in your future meetings is we're going to try to introduce you to what other counties are doing. And you'll hear about how Fond du Lac County handles skilled nursing, Dodge County, et cetera. What's unique about Washington County, and I found this in my 7 years, is this taking on this chapter 55, essentially people who could be a harm to themselves or others, is not what most other county facilities do. Dodge County is an exception, and we'll walk you through that. But generally speaking, this conversation that you're having right now appears to have never happened in a lot of these counties, where they continue on with these skilled nursing facilities, mostly because it appears to me, because of tradition, we've always done it that way. Whereas really, to me, this boils down to really this issue and a few others. Where if this service doesn't exist, then what? Okay, so as you listen and I poke into that as an issue that I found in 7 years, I don't have the answer, but I can tell you, we've had other counties come in, look at our operation, talk to us about what they do. And when I say, oh, well, what do you do with chapter 55s? I kid you not, their head goes down and they won't answer the question. I'll let you decide what happens to those people, because I don't think they even know the answer. But it's a very important difference between what we do and, for example, what a Fond du Lac County does. So just think that through and maybe find some questions that you can answer to drill down on that a little bit more. Sorry.
I have a question. Is there an age around that chapter 55, or is that open to all ages, or is it a specific age that you take in for that?
It's predominantly the elderly.
Elderly
Yes,
only, okay.
Yes. So for example, it wouldn't be a 35-year-old individual who can't care for themselves. It's predominantly 60, 65 and above. Predominantly, however, 80 plus. So generally. So on our campus, we talk about Samaritan campus as a whole. So we've got the health center, which I just talked about just a little bit ago. We also added a residential care apartment complex. We're good with the acronym, so the RCAC. And there, that's relatively new construction for us. It was constructed in June of 2006. We have 24 units. They're pretty much apartment type settings. Some that are studio and some that are one bedroom. Under that residential care apartment complex license, which is a separate license through the state of Wisconsin, we are able to provide 28 hours of total care to that individual. So that would include professional nursing, that would include hands-on care. Again, predominantly these residents are individuals that appear to be pretty independent, and they might need some guidance with their medications or reminding and again, making sure that they're socially engaged so that that psychosocial piece of their life is met. And then, as I mentioned, we also have what is known as our CBRF. Both of these are called the Fields of Washington County. Don't know why, but they are. And so that's a licensed CBRF. Again, a separate license, again, under the state of Wisconsin. And we have 31 units, predominantly family care, individuals that need that financial assistance. And there we are able to provide up to 3 hours of professional care. So, and there could be certainly some additional hands-on care there, but it's that professional license care there. So it's again part of the continuum, and we do find that residents will move from one section to another, either post-rehab or in need of care.
So what percentage is private versus public in these two things?
Percentage in the CBRF, we're probably about 80% family care or public funding. And our residential care apartment complex, we're about 60-40, so roughly 60% family care and 40% private. We find that we have more of a tendency to attract the private pay individuals to the RCAC, and then they stay for a significant number of years. And so in that case, many of them have outlived their assets. Most of the CBRF admissions are admissions where folks have been in the community, have utilized home health or all sorts of other opportunities, and then they come to us with not a lot of funding. Our last slide just shows a little bit of some of the challenges from the physical plant itself. When we first started talking about some of the needs of the Samaritan campus as a whole, one of the things that we have come in contact with over the 52 years is there are significant physical plant needs, as Josh mentioned. We worked with the county facilities team and they did a full assessment of our building. And without even adding extras, we are easily over $10 million in need. Some of you may have seen we have a truck bed off of the parking lot. It's our chiller cooler, which we're very thankful for in the summer. It just sits there in the winter. But that was a significant effort just to get that in and of itself. So we've got standbys as far as making sure that some of those operations work for us. It's not a long-term sustainable.
Is that because the air conditioning went out or you didn't have air conditioning?
No, we had air conditioning. Yeah, we have 4 units up on the roof. 3 years ago, we were down to 1.5 units that worked, and that decreased from there. So yeah, it's there, but it's no longer functioning.
How long ago was that analysis done that says you need 10 million in physical plant updates?
It was done April 10th of 2019.
Thank you.
So things like nurse call systems,
You got some big.
we have big ticket
items
items. Yes, yes. Switch gears, chillers, yeah. Yes, we do. And again, even things like a nurse call system in a cement building.
Right.
With some of the products that are out there right now, as far as wireless type things, we give IT a run for their money when we ask for things that.
I'm sure.
Yeah. So, but it was relatively recent.
Okay, thank you.
Anything else that I can answer for anybody at this point? Okay. Thank you.
Beth?
Thank you.
Dewey Driscoll.
Good evening, I'm Julie Driscoll. I'm the Director of Health and Human Services here in Washington County. I've been at Washington County almost 4 years. I come from a background of public health and child welfare. And so I'm just going to give you a little bit more in-depth information about emergency protective placement, or Chapter 55 as you guys were previously discussing. The reason we want to go into this is because it's important for you to know, as we've discussed, the role that Samaritan plays in adult protective services. So Chapter 55 is a statutory requirement put out by the state of Wisconsin. It falls into the category of elder adults at risk, which is over age 60, and then adults at risk, which is age 18 to 59. Essentially, somebody falls into a Chapter 55 when it appears that they are so totally incapable of providing for their own care or custody, and it creates a substantial risk for themselves or someone else if they're not immediately placed. This can be due to somebody having an intellectual disability, a degenerative brain disorder like dementia, or a traumatic brain injury. So generally, those are the reasons that people fall into that category. The determination of a Chapter 55 is made by law enforcement, firefighters, guardians, or other authorized representatives. Here in Washington County, the Human Services Department is the entity that is allocated to make that assessment for somebody to be deemed to fall under a Chapter 55. We call that Adult Protective Services here in the Human Services Department. Generally, we find that most of our cases are called to our crisis department, our adult protective services department from law enforcement. So we work in partnership with them and very closely with them. As Mary Beth alluded to, it's generally very late at night on the weekends. Many of these Chapter 55 cases are due to somebody having an unexpected loss of a caregiver, or they're just decompensating and they can no longer care for themselves. So they're in a state of self-neglect. So when somebody is placed under emergency protective placement, we can place them in a number of different facilities. We can place them in a hospital, a community-based residential facility, a private nursing home, adult family home, or a county nursing home. Around 2006, 2007, the Washington County Board of Supervisors designated Samaritan as our facility to place Chapter 55s. Once somebody is cleared at a medical emergency room facility, then they are transferred to a facility like Samaritan, where they are held for 72 hours awaiting a preliminary hearing. So somebody does have to go through a court process. So the court system deems this a viable Chapter 55 because you are taking away someone's rights. And so you do have to go through that process. If probable cause is met and the individual is in need of additional care, so there's no one other to care for them, no family members that can provide that care to them, then we will put them under a protective placement order. And that usually lasts up for 30 days. And during this time, that individual will continue to receive care and support at Samaritan or the other facility in which they're placed. One of the good things about the partnership with Samaritan is generally when somebody is placed there, they can bill their insurance for the cost of their care. And if they cannot, then we do have a contractual agreement with Samaritan, then the Human Services Department pays for that person's stay. I would say in my 4 years, we've probably paid for one person's stay because generally we can bill the insurance for that stay. Sometimes Samaritan is not an option. So not everybody that we place under a Chapter 55 is placed at Samaritan. And the reason for those, for Samaritan not being an option is sometimes they don't have the bed available for a specific gender. The individual is a wanderer or they're at risk for elopement. While Samaritan has dementia care, they don't have a locked dementia care facility. And so sometimes it just continues to not be a safe place for someone if they're at risk for wandering. They might be medically compromised and Samaritan doesn't feel like they can care for them properly because of their medical needs. Or they have violent or aggressive behavior, and that's a risk for other residents. I would say one of the highest needs for folks under Chapter 55 is individuals who have dementia, who are very aggressive and have violent behavior. And that's an issue throughout the state of Wisconsin and finding an appropriate facility for them. When someone is not an option for care at Samaritan, we will place them, continue to place them at the hospital until they are receive medical clearance. And then they will remain at that hospital until they have their probable cause hearing. If there's a legal decision maker, such as a power of attorney, they could be discharged home or to another facility or out of county. Generally, what we find is we have to place them out of county, which is one thing that is really a detriment to providing somebody ongoing care and support, is that they're placed far away from their home. And the cost for us, if they are to stay at a facility out of county, is anywhere from $1,500 to $3,000 a day. If they're in a hospital, they can bill their insurance for it if they have insurance. But Human Services, under statutory requirement to pay, must also pay for their care if they don't have insurance. Generally, that age they do have Medicaid or Medicare. But if their stay warrants for them to be an institute of mental disease, the IMD cannot bill insurance. And so then the Human Services Department pays for their daily rate. When we do not have a suitable placement, many times we have to send people to Winnebago Mental Health Institute. And generally speaking, that's not an appropriate placement for people with these types of needs at this age. So this is our 6-year placement data. So you can see the numbers that we're generally seeing every year. It fluctuates. These are not the numbers that we place at Samaritan. We tend to place between 40 and 50% of our placements each year at Samaritan. And again, it is because either they fit some of those other criteria, or we have some, younger adults who have intellectual disabilities, and there's a different placement for them. So that's just a general overview of Chapter 55. Are there any further in-depth questions?
Just curious, how much of the placement is voluntary?
There is no voluntary. So that's the difference.
I mean, they know they're coming. I mean, do they accept the situation? I've not ever been in a situation.
Sometimes not.
Okay.
And generally, that's where you have somebody who has dementia and they're exhibiting, behaviors that are erratic or violent. Generally, if people are in a state of self-neglect or there's no caregiver, and sometimes there's a caregiver who's not caring for them properly. Sometimes they're just very confused. There is a difference if you've heard of Chapter 51. So Chapter 51 is a different type of emergency placement that fits people who have mental illness or substance abuse, and that can be done voluntary or involuntary. And so there's just sort of a fine line between what that is and what a Chapter 55 is. So generally, it's somebody who cannot care for themselves versus somebody who's under the influence or has a severe and persistent mental illness. As Mary Beth alluded to, sometimes as people who have severe and persistent mental illness age, you're sort of always doing a little bit of, well, is it fall under Chapter 55 or does it fall under Chapter 51?
Where did Chapter 55 placements go prior to 06, 07?
Either to hospitals or other county facilities, generally Winnebago Mental Health. Great, thank you.
All right, good evening. I'm Patrick Carroll. I'm a manager in Whipley's Senior Living Healthcare Consulting Practice. On the screen in a small box is Larry Lester. He is a partner out of our Eau Claire office. He oversees the Senior Living Consulting Practice. He's been very closely involved in this project and working closely with me. But he tasked me with making the drive and coming to talk to everybody. But he's available to fill in any gaps that I leave, and also he's an extensive resource of knowledge for any questions during our discussion. So on a personal note, I'm out of our Milwaukee office. I have a wife who's also a nurse practitioner, works for the medical college, and a mom who's an RN. So I'm going to go through a lot of data and figures here, but we're not just cold-hearted accountants. That's just our job as an accounting firm. The presentation that we have was given to the county board in July 2020. And it's a summary of the initial work that we went through, which included a market study to assess demand for the county for senior living services, and then a status quo financial model analysis. So when we say status quo, basically it's what if Samaritan remains as is? What do the numbers look like? So that's what we're going to go through tonight. Really hit on number 2 right away there. We'll get right into slide 5, which is, I'm going to move quickly.
Oh, yeah, that's great. I'm not advancing.
She just walked over here.
There you go, that'll do it.
That's all it takes.
Ready?
Yes. So some of these slides, again, since we've been through this presentation and we don't want to get into too much detail, I'll go through quicker than others, but wanted to provide you with a full presentation so that you have that available to you. So we're starting with kind of a summary of the nursing home bed demand analysis. So as Mary Beth mentioned, Samaritan Nursing Home is currently licensed at 131 beds. We ran an analysis for the demand for nursing home beds for a primary market area, which we defined as the 2 zip codes in West Bend. And then we also looked at total market area, which we defined as the county as a whole. So for the county as a whole and also for the West Bend area, we found that the current supply of nursing home beds is higher than the actual demand. And at current day, that's approximately 75 beds for the county, and it's projected to increase to 120 over the next 5-year period. And when we get into the actual demand slides, I'll kind of talk through a little bit of why that is. But basically consistent with the trends in the majority of the places in Wisconsin, the area is overbedded as far as nursing home beds are concerned. We also did a little bit of a analysis of the other providers, skilled nursing home providers in the area, and found that at any given time, they had approximately 80 open beds. So that kind of jived with our nursing home demand analysis. Cedar Communities did downsize because they're seeing the same trend. At the time of the analysis, I think they were at about 110 beds. They're down to 90 beds right now. So it's kind of the high level findings on the nursing home bed demand. This slide summarizes the actual math that's behind it. And so what we do is we look at the population data for the defined market areas, which again was the West Bend zip codes and then the county. And we take actual utilization data, nursing home utilization data for, I'll refer to it as your region. So it's outside of Washington County, but it's kind of the greater area. So for individuals in these age groups, 20 to 64, 65 to 74, 75 to 84, 85 plus, about what's the actual utilization within those groups. So we apply it to the population, and then we look at the total number of beds in the area, and that gets us to our kind of our bottom line that shows you the overcapacity for both the primary market area and the total market area. And the findings are pretty consistent. Before I go off, I'll stop right there and see if there's any questions on that.
The industry as a whole has seen a pretty heavy drop since the pandemic started. Have you guys revisited these numbers since July of last year based on the number of deaths, people pulling family members out of long-term care facilities? And I'm just curious what that number is today.
Yeah, so we have not done a re-analysis of this, partially because the kind of other track that we're working on is looking at downsizing the number of beds at both Samaritan and potentially Cedar. So it's potentially irrelevant, but it's also difficult at this time to run those numbers and say, hey, during this time of COVID, what's the assumptions about how utilization is going to change in year 2, 3, 4, 5? We don't really have historic data on what it's going to look like, so you have to make some pretty significant assumptions. We do, in these numbers, look at the historic trends in nursing home utilization, and we apply a declining utilization over the 5-year period. So within these, it is assumed that utilization will continue to decline without taking into account COVID, but we do assume that utilization will decline in these results. Slide 7, we get into the CBRF demand analysis. And with the CBRF and both the RCAC, there you're looking at 2 different types of residents. One is the private pay type resident, and that's individuals who can afford to pay out of pocket for their care. And then there's the family care resident. And family care is basically a Medicaid waiver program. So it's another Medicaid type of program for individuals who don't necessarily have the assets or income to be able to pay for care.
Is that what would be considered community access programs? Is that part of that? Or do they not even have that anymore, right?
No, so the family care is, it's a Medicaid waiver program that's reimbursed by the state and was, well, it pays for a number of things, but specific to the assisted living industry, it's a Medicaid payer for people in those assisted living settings. And like Medicaid in the nursing home, it's reimbursement's poor and doesn't really fully pay for the cost of care. So when we look at our assisted living demand analysis, we kind of focus on private pay. So how many folks are out there that can afford to pay out of pocket for assisted living services versus how many CBRF and RCAC beds are available for private pay type residents. Because when you're looking at providers outside of Samaritan and the county, most of those other providers want to attract the private pay individuals, again, because of those issues with reimbursement. They might serve a small portion of family care. They might set aside a certain number of beds to serve family care residents, but they certainly don't want that to be their overwhelming population. So the findings on the private pay side is that the current available beds is meeting demand, and there's likely a little bit of saturation. But when you look at Samaritan's niche or the field's niche, there is going to be a need today and increasing going forward to offer either an affordable private pay option or to serve that family care group. So there's
affordable pay today in a community-based RNC.
Well, that's an interesting item to try to define. It's, I would say it would be a monthly rate, all-in monthly rate at a CBRF of maybe 4,000, which is still a pretty significant chunk of change, but you see CBRF private pay rates when you add room and board plus care, plus maybe some meals or housekeeping or whatever other services are outside of that base rate. That can be 5, 6, even upwards of 7. And that's just for elderly. And then when you look at memory care specific, it can be 7, 8, 9, even 10 plus at some providers. So $4,000 a month is still significant price tag, but when you're talking CBRF, that would kind of be where our head would be at as far as affordable. So really the bottom line as far as the Samaritan CBRF is you're not going to see an uptick in the number of private pay residents, but there's certainly a need to be filled for the family care population. Let's see.
Are there any changes from the state going to be happening in the next few years that you know of or predict?
That's.
You tell us who the governor is gonna be, Dal, and we'll tell you. Well, I hope I know who he is.
That's another tough one, especially when it comes to family care. On the Medicaid side, the last budget provided for a fairly significant increase in Medicaid dollars, which certainly didn't meet the needs, but historically speaking, it was significant. On the family care side, the money gets funneled from the state to a managed care organization, and then from the managed care organization to the providers. And there's been a lot of issues with clarity behind how the managed care organization is actually setting rates. And that's something that's being discussed by the senior living associations in the state and with the state and the MCOs themselves. And I do not have a great answer as far as what the future is going to look like as far as improvement in reimbursement from family care. Family care program is not guaranteed to remain. I personally don't think it's going anywhere in the near term. I think that with the shift in consumer demands and the fact that cost of care in assisted living settings lower than a nursing home, some sort of Medicare program is going to remain. But as far as if there's going to be any significant changes to family care, I don't know. So slide 8 is some more bullet points on CBRF. I think we kind of covered those. Slide 9, RCAC. It's pretty much a similar story, although as far as there's no additional need for new private pay RCAC units. In fact, since we did the demand analysis, I'm aware of at least 1, maybe 2 new RCACs that were approved in the county. So that's going to further impact the ability to attract private pay residents. However, as Mary Beth pointed out, because it's a newer type of facility as far as Samaritan as a whole, and the fact that people enter the RCAC before they really spend down, the RCAC has performed better compared to the CBRF as far as having a better payer mix. So when we did it, it was about 57% were private pay residents, which is consistent with the 60-40 and Mary Beth quoted. And there's always historically been high occupancy at the RCAC, so we foresee that there's no reason to, from a demand perspective, there's no reason to discontinue RCAC operations. So that kind of summarizes the findings as, again, just from a pure demand perspective. There's a little bullet point here on staffing shortages. I'm gonna get into that on the next set of slides, and we'll have a little more detailed comments on that, so I'll skip over that for now. I mentioned we did a competitive analysis. I'm not gonna spend a ton of time on these slides, but it basically summarizes on slide 11, the providers in the county, how many beds they're licensed for, and the occupancy levels that we found. Again, kind of low 80s, high 70s, again suggesting that the county's overbedded. Slide 13 is just a little additional supplemental data on the other providers, not only in the county, but in the region. Skip over that. Skip over slide 14 as well. Slide 15 summarizes the CBRF providers in the county. These are the CBRF providers that are just providing care to either frail elderly type population or memory care population. There's other sorts of populations that CBRF serve. These are the ones that would be providing care to the same type of population as the field CBRF. Overall occupancy levels were high for the county. Slide 16 is the RCACs. Again, about 500 units in the county, which sounds like that'll be increasing over the next year or two. Again, the surveys that we did found high occupancy levels, upper 90s is pretty high occupancy levels in a senior living setting. So that's it on the other providers that we looked at. And again, those number of units are taken into account when we're doing our demand analysis. So slide 18, getting into the demographics. This is kind of on a macro level to set the stage on the aging population. So in 2021, the first baby boomers, according to my definition on there, started to turn 75. And in any given senior living setting, the average age of resident is approximately 85. So in memory care, I think it's 84. In skilled nursing, I think it's 86. But kind of across the board, give or take a year or two here and there, the average age that the Samaritan campus is serving is folks about 85. So when I was looking at the demand analysis that I first referenced, we were looking at 2021 through 2025. And with the baby boomers, we all hear about this big oncoming population that's going to need to be served. Well, that's not going to be reflected in our demand calculations because that big wave's not here yet. It's going to be another 10-ish years before that population really starts to hit the senior living industry. So when we look at the demand analysis and talk about over the next 5 years, there's not a need for approximately 80 nursing home beds in the county. There's also, there's the short-term planning that we're looking at, but in the back of the mind, there needs to be a thought kept there about, okay, so what about year 2031, 2035? What's it going to look like? And it's difficult to project that demand because over the past, I think it's 30 years, every year there's been a decline in nursing home utilization within the state. So if you want to say, hey, Patrick, we got this big oncoming baby boom that's going to hit the industry in 10 years. what's gonna be the need there? Well, we don't really know if nursing home utilization is gonna continue to decline 10 years from now, or if it's gonna stabilize. So when we talk through strategic planning with our clients and we're doing this data analysis, the kind of message is you have to plan for the short term. You can't sit here and operate with an overbuilt nursing home waiting for the baby boom because of the financial impact. So when and if you're making some capital improvements or maybe even a building project, it's addressing the short term but planning for the long term. So I just wanted to clarify that in case the message isn't jiving that right now you're overbedded, but there's this big population 10 years down the road. So flipping to slide 19, this is population data for the county. Again, looking at that 5-year period. And when we talked about the nursing home bed demand and having it split out by age cohort, we looked at age group 85 plus, which is the highest utilization numbers. Over the 5-year period, that group's only projected to increase 5%. But if you kind of drop down below and look at the population age 75 to 84, that's projected to increase 35% over the 5-year period. So that's where we're talking about the short-term projections versus that's the baby boom group. And that's going to start to hit 2025 to 2030, 2030 to 2035. Slide 20 is the worker ratio. And this gets to that staffing shortage comment that I skipped over. And so this is long-term projections for Washington County. And when we say worker ratio, we're defining it as individuals aged 20 to 64 compared to individuals aged 65 and older and then 85 and older. So we show the county ratio versus Wisconsin versus national just for comparative purposes. And in Washington County, over the period of 2020 to 2030, the worker ratio is projected to decrease by 30%. So that's kind of the other side of the demand factor. There's this oncoming group that's going to need care, but there's also going to be fewer and fewer individuals available to be able to provide care for that population. So again, when we're looking at our strategic planning, we know that there's this other issue that needs to be factored in, which is being able to attract staff to be able to care for those individuals. Slide 21, I won't spend a ton of time on that, but we look at household income when we're doing our assisted living demand projections, again, to project the number of individuals that can afford to pay for services out of pocket. So we're looking at those by income group and then age group. So that's kind of the highlights there. Flipping ahead to the next section, the facilities assessment. And Josh hit on this and so did Mary Beth. And we weren't involved in this, but I included it in the presentation as data that really gets into, again, considerations when you're looking at the future for Samaritan. And I'll flip through it pretty quickly, but basically each slide is broken out by time frame. So you have the next 6 to 12 months, the next 2 years, 3 to 5, And then slide 35, that's the total of the facility assessment that was conducted by Washington County's, I think, maintenance group. But for the next 5 years, these items that need to be addressed have a price tag of $5 million. And obviously, there's some other items that Mary Beth and Josh are aware of that double that. But this is put in there to show that there's, over the next 5 years, there's $5 million of things that need to be addressed. And that's not taking into account the fact that when you address those, you're still left with an old facility that needs plenty of other investment. So that's really the point on those slides. So flipping forward to slide 47, we get into the financial model. And this, again, was done early in the year 2020. So this doesn't have much of an impact of what occurred with COVID-19. This is based on the analysis for the most part prior to that. I'll argue that on our other track, while COVID-19 certainly needs to be taken into account, we also want to look at what are the numbers going to look like when we get back to some normalcy. So it needs to not be ignored, but it's a little bit irrelevant. So this would be the results in a normal environment and prior to any impact of COVID-19. So some just highlights the financial performance you're going to see. We forecasted that to deteriorate over the period. We didn't build in significant investments for the capital items that we noted in the previous slides. We don't have any new debt or anything. It's truly a status quo. What if Samaritan just continues to operate as is? Slide 38, again, we assumed census levels were going to be the same, which those were significantly higher at the time than they are right now. No changes in payer mix. You can see I kind of have that detailed out, but it shows that over 70% of your residents are either on the Medicaid or family care program. Assume some sort of revenue inflation based on historical data. We, on the flip side, assume some expense inflation. There's no county tax levy funds in here. It's really based on the operations of Samaritan. One item that I do want to point out is the supplemental payment program. So county nursing homes receive supplemental payments from the state because the state recognizes that county nursing homes typically provide care to a higher number of Medicaid residents than maybe your for-profit or even your not-for-profit nursing homes would. So to help supplement the gap between the cost of care and reimbursement from Medicaid, there's this supplemental payment program. So payments from that program are included in the financial model. However, in fiscal year 19 and fiscal year 18, there was a surplus in that program. So Samaritan received an additional $700,000 on top of what they were awarded at the beginning of the year. For the projection period, we assumed a rate at kind of the $1.3 million based on 17, 16, 15 and what they were awarded at the beginning of the year. We didn't want to assume over the next 5 years that there's gonna be an additional $700,000 of revenue. So, that's excluded, but also if you're looking at the actual fiscal year 19 numbers, there's an additional 700,000. So we just want to be clear and call that out, that we didn't assume an additional 700,000 for the forecast period. Slide 40, basically a summary of kind of the inflationary increases that we assumed. Another item I want to point out is there's a WRS pension expense that's on Samaritan's books. That's Wisconsin Retirement Services, I think that stands for. But that's an expense item that's on Samaritan's books, but it's a non-cash item, and Samaritan doesn't have any control over it. So it's money that's held by the state, and depending on how the market goes, Samaritan gets a notice from the state, hey, you need to book either an unrealized gain or loss on this. So it's a non-cash item that's not related to operations. It's excluded from our projections. But it is, again, on the Samaritan financials. So we just want to be clear where our numbers are differing from what you might see on financials. So slide 41, it's really a statement of operating revenue and expenses. So top section is your resident service revenue from the skilled nursing facility and the assisted living facility. Then you have your other operating revenue. You have your operating expenses. We have a bottom line income loss from operations. You can see in 2019, I kind of have that true up to remove the WRS expense. And then I kind of titled the new bottom line income loss from true up. So you can see that there's projected to be a continued decline in performance based on operations. And really, it's the gap where 70% of your residents are on Medicaid, and there's the increase in reimbursement there does not keep up with the increase in expenses. You have your most significant expense item is staffing, salaries and wages. And to continue to be able to attract employees, you need to be able to have attractive wage rates. So the combination of an older facility and a payer mix that isn't favorable with inflation to expenses outpacing the increase in revenue, that's kind of why you arrive at that bottom line. Below that, we kind of have a little bit of a cash flow number. It's not a true cash flow, but we have back depreciation and provision from bad debts, and then add in there your debt service payment to kind of give you an idea of the cash flow number. So that's the story there, which kind of leads us to next steps and what you're here to discuss, which is, does Samaritan remain in the business? And these next steps are a little bit old. These were next steps as of July, but it's kind of the same story. We're here to provide you with the data and the analysis to give you background on not only why Samaritan exists and who Samaritan serves in the county and the benefits, but also the numbers to show the financial performance, and then also the need, the demand for senior living services in the county. with that, maybe I'll check in with Larry quick to see if he has anything to add on. Otherwise, certainly happy to field questions.
He's talking, but
He's talking, I can't hear him.
Here, let me stop sharing. Larry, can you hear us? Sure, it might be on his end.
Doesn't look muted.
He's not muted here.
Can you hear me?
There we go.
Can you hear now?
Yeah.
Yeah, I just wanted, somebody mentioned the community options program. That was actually replaced by family care. So that's a program that doesn't exist anymore and was replaced by family care. So just so everybody's clear that program used to have a waiting list. So you had to wait to, in essence, for a slot to open in that program, whereas family care has really eliminated the waiting list part of it. So, but otherwise, that's my only comment.
The only thing I would add to these guys' presentation is what happened between July and February. So I mentioned that there's parallel tracks running. We wanted to keep this discussion moving. As you can see, the building and the state it's at, we want to move on and come to a conclusion. So this conversation was happening literally at the end of the last time this was presented. The president and CEO, I think that's the right title, of Cedar Campus came to Matt and said, you know, we'd be interested in talking public-private partnership with you. You saw in the presentation from Whippley that they have a large section of their campus that's been vacated. It creates opportunity. That conversation, we've engaged with Whippley again in partnership with Cedar. So that analysis is being done now. Can that marriage work between our two organizations? So what I'm telling you is every option's on the table as far as we're concerned. Both new construction, which is listed at the end of your presentation here, as well as a public-private option where we're working with Cedar Campus and the last of exiting the business. So all of those options remain on the table. But that's what's really delayed us from July until now is that little factoid from Cedar Campus and now starting to work in that variety as well. So by the time we hit that April deadline on the other sheet of paper going to the county board, we'll have your recommendation along with the analysis you just saw, plus an analysis on Cedar Campus.
Patrick, I have a question. When it says status quo, the statement of revenue and expenses, is this with the model of 50 beds? Is this?
No, so the status quo model here is as you were operating. So it's just 131 beds at your historic occupancy levels and assuming no changes in operations. So if there's no changes, what are we forecasting the bottom line to look like?
Right. Yeah. And did you want to discuss at this time where Whippley was looking at 50 beds for skilled nursing and what that might look like?
Yeah, I can talk about it in general.
Right.
So at the time, the thought was the next step would be to take the status quo model and build on it to assume downsizing the nursing home to either 50 beds or somewhere around 80 beds, something to that, which was kind of driven by the demand analysis and the fact that going from 130 to 50, that kind of eats up that full projection of that full projection of the county being overbedded by 75 beds, or 80, which is kind of somewhere in the middle. And the reason 50 beds is kind of a magic number is the state offers an incentive payment. It's kind of called a small home incentive payment. So if you're 50 beds or lower, there's an increase in your Medicaid payment rate. So that's why you look at, okay, what does the model look like if we go down to 50? How much does that extra payment from the state impact the financials versus doing kind of a medium between going from 130 to 80 versus.
There's no
down to
guarantee
50.
that that's gonna last.
There's no guarantee that it's gonna last. It's been, Larry, how long has that been available now?
It's been here more than 25 years, so, I mean, it's been a part of the methods of reimbursement for at least 25 years in Wisconsin, so.
So, and then the other consideration with downsizing is, you know, it seems like the county's overbedded, but also we know that there's staff shortages coming up. So it's the other kind of thought process behind looking at downsizing. So that was going to be the next steps, just looking at new construction and smaller type of nursing home, keeping the CBRF, not doing anything with the RCAC, keeping that as is because high occupancy and favorable payer mix, which kind of got delayed as Cedar Community entered the discussion.
On the slide of status quo statement of revenue expenses, this thing we just talked about, and maybe this is for you, Mary Beth, but just out of curiosity, when the actual supplies and other was 4.7 in 2019, but budgeted for 3.8 of 2020, what was the difference there?
I can't tell you without pulling some of that. I believe the big piece would be purchase services that would have fallen under that category as far as the number of outside agency
Sure.
staff that we utilized,
Okay.
which was very significant coming up. We are down to one staff person, and that's the positive of COVID, because we didn't bring any outside staff in.
Sure.
So that would be based on purchase services.
Thank you.
But if you had 50 beds, you'd still have all the facility needs, the parking lot, the coolers, and all the rest of it.
Mm-hmm. Yeah, obviously there's still kind of overhead costs. It would be a newer building, so some of that would be offset. But yes, you still have.
So it would be eliminating the building and just putting in a new building.
That was the thought. Yeah, was looking at a new building. There's with the kind of point with the 5 million of identified expenses in the next 5 years is you do all that and you're still left with an old building that's going to need to be invested in.
Right.
So that was a thought as we were looking at construction of a new either 50 or 80 somewhere in there nursing home and CBRF and RCAC as is.
So then you're making a commitment for another 25, 30 years.
Correct.
At least.
And 25 years is a golden number for us, because when you do the math on what does it take for us to hit the baby boomers, what does it take for us to get through the bulk of the baby boomers, you're looking at right about that 25-year point, and then we expect the bell curve to start dropping off again. The other thing to note, I just wrote in my notes, we might have glossed over it. Samaritan has approximately $5 million in debt that is still outstanding. You notice there was $600,000 in debt payments. That cannot be called early. If I recall, do you remember what your debt goes to?
No.
So anyway, no matter what we do, that 5 million in debt is gonna be hanging over us. Basically, every single scenario that we're contemplating, as I mentioned, new construction, public-private partnership, accident industry, every scenario, the building that we have today, save potentially the RCAC, comes down in every one of those scenarios. Whether we build there, or whether we build off campus, or whether we build at Cedar, or not build at all, that's all to be determined. But we were trying, as Patrick was alluding to hit those key demographics, as well as really narrow our focus in on the, as I think was pointed out, Julie pointed out earlier, that indigent population, particularly chapter 55s, and then what? So that's where we really started to zoom in our focus, which the county's been doing for the last 7 or 8 years. Where do we really fit? What is our niche in the market space if we're going to exist?
Mary Beth, oh, I'm sorry.
Go ahead.
I was just gonna ask a little bit more about the operations, a little bit. So it's obvious that you and your team do a fantastic job of caring for your residents, right? You got great surveys, so that's tremendous, but we've got a lot of the expenses on the building infrastructure needs, and you guys are able to overcome all that, but are there any large capital equipment purchases that you might need to make in the facility, whether it be updating beds, implementing a new EMR system, anything along those lines? I know we talked about the nurse call a little bit, but just trying to think what else might be out there.
Right. So EMR is kind of on the discussion table. The nurse call is a good habit. The carpet and the environment itself is from 2008. So generally in a long-term facility, carpet 5 to 7 years is right about there. So those kinds of things, just more of a cosmetic update, those would be important. As far as what do we need, we are hoping and praying that nothing happens with the nurse call system. So all of those kinds of things we really pushed off as best we can.
How are your operations impacted this year? I know we can't forecast the pandemic and what's gonna happen in the future, but what happened to your overall occupancy and what happened to expenses as well?
Sure. So overall, both in the CBRF and RCAC, our occupancy has remained at a high 95 to 100% occupancy. So we've been fortunate with that. Our nursing home dropped about 20%. You had mentioned a couple people going home. We actually had 2 that was certainly a viable option for families. Most families, however, did not. Because of COVID, as I mentioned, the purchase services for long-term, for the agencies, nursing staff, we were forced to figure it out overnight.
Sure, yeah.
And I had said when I first started, man, we're not gonna use outside agency. I don't like using outside agency. And it's pulling teeth because that's what people are used to. So we had to overnight. And that was a huge cost. That was about $1 million cost for us last year. So that has dropped significantly. As Patrick mentioned about from an operations standpoint, our average Medicare, so the rehab population, we get about an average of $515 a day for those individuals. On a Medicaid population, we just got a rate increase, about $190 a day. And then our private pay sits in between, about $350, $360. So one of our strategies has been to help not only address the market needs, but also address the financial, is make sure that we are darn good on that rehab, so that we have not so much repeat customers, but individuals from word of mouth. So those have been some of our operational strategies, predominantly purchase services as well as our rehab.
Thank you.
Question on the back?
May I say something? My name's Dan Stuffel. I was a county board supervisor as chairman of the Samaritan committee for a number of years. I think it might be instructive for this committee to understand
that up until, and I don't have the numbers because I'm not there, but Samaritan ran a deficit year after year after year after year through my tenure when I started in 1982 on the county board until I think sometime in the 2000s. So two things changed that. One was, I think, an administrator who really grabbed the bull by the horns and said this is acceptable, and the excess funding that we got from the assisted living, CBRF. So I just don't want the idea to be that Samaritan always ran on its own. It had government help up until that period. So now there's a period where it's running as an enterprise fund, and it is, at least to my recollection, running at a net profit, although small when you consider the size of the budget. So, I just want people to remember or understand that for a number of years, it was subsidized by the county also. So as we approach what looks like either another county subsidy or a change in direction, that is not the first time in history that will happen. And just the other thing, maybe, I don't know who would be best to address this, but I think it would also be instructive to have people understand why nursing home beds utilization is dropping so dramatically.
Yeah, thank you for asking that. So there's a couple factors in that. One is consumer preference and the fact that as the I guess as the nursing home industry is beginning to serve a little bit of a different consumer as generations kind of change. Older generations were just used to you go to the nursing home and that's how it is. Newer generations have the choice of home care, the desire to want to stay home longer, and then also the growth of the assisted living industry. And with the assisted living industry, also the implementation of the family care program. To Larry's point, there was previously wait lists. Now it's basically a Medicaid program. So people that who needed to rely on Medicaid for care, their only choice was the nursing home. It's now the availability to potentially go into an assisted living setting, which again is more desirable to the consumer because it's not, it's less institutional. It's just more desirable home-like setting. So the availability of assisted living and consumer preferences are two significant factors towards the declining nursing home utilization. And it's also a reason why we assume nursing home utilization will continue to decline because the number of assisted living beds continues to increase. And also assisted livings are continuing to serve a higher and higher acuity type resident. So some individuals that, again, may have been in the nursing home in the past are now being cared for in an assisted living setting. And I don't know if you have any other thoughts that you were thinking about that you want to throw in there.
Well, just for historical perspectives, there were developmentally disabled people who had a nursing home bed in Samaritan in the 60s and 70s. That's obviously totally gone. Mm-hmm. So the acuity is increasing and the willingness to be in a nursing home is decreasing.
Right. Yeah.
I found out this with business, over a period of time, you get somebody into your place that's kind of confused, you square them away with meals and proper medications, proper doctor intervention, they improve a great deal. Some of them do. So, I mean, that's always part of what they need. That's that personal attention they got.
Mm-hmm.
Are there any thoughts of increasing your CBRF in those facilities. Instead of maybe an 80-bed nursing home, to have, well, Ivy Manor has the assisted living facility, but they also have a building for memory care. New Perspectives also has memory care. So to kind of, if that is the primary need for for nursing home care, would that be a possibility?
So that's certainly something that the group could discuss. If there were to be an expansion of the number of CBRF beds and or a specialization into memory care. So just first, the expansion of the number of CBRF beds, it'll likely be filled by mostly family care residents, which again would have a negative impact to the financial performance. So it's certainly when we talk with clients about decreasing the number of nursing home beds, increasing CBRF beds is one strategy to have a place for people to go to and be served in a lower cost of care setting. But the reality for Samaritan is it's unlikely that there'll be significant impact or increase to the number of private pay residents. It would more likely be family care residents, which again would have the negative impact on the financial side. On the memory care piece, it's the same issue, probably be family care residents, and also it's increased staffing needs. So you need higher number of staff to be able to care for those residents, and that's one of the big cost items. And also, the trend or the concern about the trend towards the ability to be able to track staff. So it's not that we're here saying you shouldn't do it, but when we would do a financial analysis on it, that would be the results of just the financial analysis. So the question as to should the county make that available is a different question, but on the financial side, that's the considerations.
And this is why we've framed the policy question around should we stay in the business? Because diving down the rabbit hole of which one of the 560 ways to do this business will take forever. But you'll notice on the process timeline in February, we're talking with the Department of Health and Human Services from the state. And one of the components of that discussion is talking about statutorily counties being in this business. There's no mandate, as you've heard, there's only, I think, 42 counties in the whole state that are in this business anymore, and that number is dwindling. But there's reasons to, and you've heard some of them today. So there's nothing that says we must be in the business. I think there's data that points to why it might make sense to stay in the business, which I think is what you're alluding to. But really, this group needs to stay at the level of, do we stay in it for those reasons, or do we get out of it because we don't need to be in it? That's what this group is needed for. Once you answer that question as a group and give your guidance to Human Services, Health and Human Services, I mean, they are more than capable of taking the public, they're elected to do this, to take the public policy discussion of, okay, we're gonna stay in the business, how do we do it? We're gonna get out of the business, how do we do it? That part, we have plenty of expertise in.
Winnebago Mental Health, is that a state facility? Or is that
Yes.
another county facility, a state
That's
facility?
right,
So
by the state.
if Samaritan didn't exist, our county folks would likely go there unless there was another mechanism put in place.
Yeah, it's generally the last resort for us. But when we don't have a place to send somebody, that's where we can always rely on sending somebody. We pay about $1,800 a day to send somebody to Winnebago. It's not a long-term facility, so it's generally a short-term stay till you can figure something else out. But when you're sort of, when you don't have a lot of choices, you know, we utilize Winnebago. It's not where people get long-term treatment or recovery. It's essentially a stabilization facility when we don't have other choices.
And then,
$1,700.
1,700 a day.
and then is, you mentioned a possible partnership with Cedar Community. The fact that they're not-for-profit, do they have access to funding that a for-profit business wouldn't have? Meaning, if you can partner up with a nonprofit, can you partner up with somebody who will actually pay property taxes and operate a business?
Yes.
Or have you considered that? Have you considered putting the Samaritan on the market? And I think that goes to, should we stay in the business? And if you guys will look at those options pending the recommendation from this committee, then I'll leave it alone. But if you can partner with someone who's not for profit, can you partner with somebody that is?
Well, I'd like to answer that. So when we say a partnership, it's not really a partnership where you have, at the end of the day, one administrator, one director of nursing, but rather it's they have excess space now because of the downsizing. And what we would do is lease property. And then we would move in there instead of trying to dump $5 million into an old building. And they have a beautiful campus. And we've been working very diligently with them. And we would be downsizing because that's part of the whole game, not to increase beds nor stay the same, but to downsize because the issue that hasn't been addressed yet, and it may be addressed more next time we meet, but the issue really is what happens to whether they're family care or their Title 19. Historically, no one takes them or a small percentage. So that's why where Josh challenges you, forget the finance at this moment. We can never forget finances, but forget it for a moment and decide philosophically. Historically, we've taken care of those less fortunate. Do we continue that? And 37 counties are in the game right now saying, yes, we'll continue that with 42 or 43 nursing homes. And of that, that's a small number out of 355 nursing homes, but that makes up 20% of all the nursing home residents. But anyway, so we've got to decide what makes sense. Do we say go elsewhere, find another county? It's so interesting. We have a contract with Clearview, Dodge County. They do a very good job. But that contract is when we have a Chapter 55, if we can't take them or we don't exist, we pay the daily rate. Plus they gain, the state pays them the daily rate. They're one of 3 or 4 special nursing homes that they get to double dip or receive double the daily pay. So there's no such thing as a free lunch. And so consequently, either we decide, let's look at it economically and let's try to be prudent, but still have the capacity to serve those in need, or let's get out of the business, but the price tag doesn't go away. We will be paying and we won't get reimbursed when we are charged in sending them places.
What would be the capacity picking up at Cedar Lake?
We could go, for example, we could go somewhere 50 to 80.
That would replace our problems here then.
Yeah, that would solve that. We could do CBRF. Today we have 31. We could go up to 34.
How many would CBRF beds are out in the community that you could use?
Well, the problem is we could build 100 and compete with the private. That's not what the taxpayers are paying us to do. We're here to show and serve those in need. And that's what we don't want to do. Part of the master plan was for Cedar to eventually build independent living. But the board, correctly so, ruled that no, we're encroaching in the private sector. The private sector will take care of that. But not this population. When we say chapter 55, you think, okay, it's a resident that comes in and you provide medication and you're fine, and you know this, Dale. But there are times that resident is yelling, is stripping, is running around, is punching, is kicking. Sometimes we have to have a one-on-one for all 3 shifts so they don't hurt themselves or others. How many private nursing homes will take them? That's our problem.
Getting back to Craig's question, can you speak to what family care, chapter 55 specifically, if we tried to shift that to the private sector, what does that actually practically mean?
Well,
does that happen, et cetera?
Yeah, so I guess on family care, not chapter 55, but just family care in general. If you're looking at the private assisted living providers, and this is either for-profit or not-for-profit organizations, generally a majority of providers either cap the number of family care residents they'll take, some won't take any, and then you'll have some providers that will take a healthy amount. But for the most part, if you're looking at a for-profit or a not-for-profit assisted living provider, there's X number of family care residents that will serve, and that's it, because the reimbursement doesn't cover the cost of care. What it does do is for the not-for-profit, it either fulfills a mission a little bit, or if it's managed properly as far as the number of staff that you have, it can cover some overhead expenses. And that would be why they would take some family care.
Does family care come from the state?
So family care is a state program.
Okay. So that the county could supplement that a little to make it more worthwhile for them without the big, large expense. I mean, you wouldn't have a maintenance problems, you wouldn't have a whole bunch of problems. The state would, their county would not have those problems.
Well, so the family care program, the individual signs up for family care. And then family care contracts with the senior living provider and tells the resident that these are the providers that we're contracted with that you can go to. I don't think that the county could have an agreement with that provider to offer to supplement that. I'm not aware of anything like that being available.
Well, I mean, it would still probably be cheaper than having your own facility and staffing, of course, that'd be hard.
Yeah, staffing is certainly an issue, and yeah, I mean, it's a fact that the cost to care for those residents isn't met with adequate reimbursement.
Well, staffing challenges aren't going away anytime soon.
No, it's a tough job. It's hard to find people that will willing to work that hard.
The staffing challenges are just beginning.
Yes.
Just to close the Cedar loop, so I get it, you're really not partnering with them. You would be quote unquote renting space from them.
Correct.
Doing your function in their building to avoid some of the capital expenses that you'd have. And then they would likely, I would guess, if they're taking family care folks, they would no longer have to take some of those family care folks, get them off of
You're exactly right. It would be a more economical because we could share services. We could buy food services, for example, from them and not have our own kitchen. One of the pieces where Patrick mentioned a special payment where counties are entitled, if you have Title 19, skilled nursing residents, we get a special payment twice a year because we're county. Other nursing homes can't receive that. So that's one of the advantages that partnering with Cedar would help.
You don't have to put a new roof on the place then.
Right.
What's the negative around that? What is the concern?
Well, the real key is we could walk away. It's a nightmare, and I may show that to you. I want to talk to the chairperson this week as to what does he want on the agenda. But it's a nightmare when you close a nursing home and we have to try to place 75 people. They could be placed anywhere in Wisconsin. And then the families would have to go visit in those guys. It's a real nightmare. And when you do that, you don't magically change and swap at that moment. What you do is a gradual, and your staff are constantly leaving because they know there's no future.
Mm-hmm.
So it is a nightmare to close a nursing home. And very costly because you end up paying exorbitantly for staff to maintain them while you're doing that process.
So I just wanted to point out we're at 2 hours in our meeting.
Yeah,
Which is about the time we said we would probably transition to out of the meeting activities.
Yeah.
So I think it would probably be helpful if I may interject for us to discuss future meeting dates, if that's okay. And I can also suggest that all of you have my email address. So if you have additional questions that we didn't get to this evening, feel free to email me and I will send them to the appropriate person behind me to respond directly. And we're gonna keep a kind of a running Q&A type response so that if one of you asks a question, all of you will get the benefit, including you, Jason, on the screen. I don't want to forget about you, so that you all have the benefit from that knowledge. So there is the sheet of paper that has the process timeline. We do have February 22nd already confirmed. So tonight was really to set kind of the stage of what the current situation is here at the county. And what we have been doing for long-term care and kind of what the status quo looks like. Next meeting is really going to talk about what other counties are doing. And so we get a kind of an understanding then of what the landscape is across Wisconsin. And so we'll have a couple of presentations on that. You heard Josh talk about before that the task is really to make a recommendation to the Human Services Committee and then to the county board. And the reason why the county board needs to act fairly soon on this in April is that there's budgetary considerations. Am I correct, Josh? Yep. Okay. So although it seems very aggressive for this group to reach a decision, a vote, it is necessary for budgetary considerations of the county. And if you haven't heard, we're going to have a biannual budget, so a 2-year budget, which is exciting as well. So lots of considerations as we move forward. So I guess my question is, after February 22nd, I put in March 1st as a next date to meet. Does that work for all of you? And if not, is there a suggestion for a different date?
Works for me.
I'd say pick some dates, and as long as the majority can make it. You did a yeoman's work getting us all coordinated the first time around. It took you a couple of bats to get it to happen, but unless there's any major objections to your schedule here.
Great, so we'll keep them March 1st. And then hopefully a recommendation, there will be a presentation to the county board on March 10th. So you're welcome to attend that as well. And then one thought was that feedback from the county board. If you wanted to meet and discuss that feedback before a recommendation was given to the Health and Human Services Committee, we could do that on March 15th as a possibility. And we will have Zoom capability for all these meetings. So if you're unable to attend in person, there's always the remote option as well. Okay, thank you for that. Were there any other questions or suggestions for me or for the group? Thank you for letting me take over.
Taking over. Was that facilitated discussion? Was that our question and answer round robin? Is that what?
For tonight's purposes, yes.
And adjourn, or we need a motion to adjourn?
You can adjourn, you're the chair.
Anybody not want to adjourn? Or adjourn?